Hello, and thank you for joining us. Today is the Newborn Screening Communication presentation on newborn screening normal results. Today is October 22nd, and we're pleased to have with us two speakers that will be talking about the newborn screening normal results. Dr. Susan A. Berry is the Division Director for Genetics and Metabolism in the Department of Pediatrics at the University of Minnesota. She's been at the University of Minnesota since 1978, where she completed her residency in pediatrics and was a fellow in medical genetics. Dr. Berry joined the staff of the department in 1984 and is currently a professor in the departments of pediatrics, ophthalmology and genetics, cell biology, and development. She's a member of the Minnesota Department of Health Newborn Screening Advisory Committee, the Society for Inherited Metabolic Disease, the American Society of Human Genetics, and is a fellow of the American Academy of Pediatrics and of the American College of Medical Genetics. She's board certified by the ABP and the American Board of Medical Genetics. As a nationally recognized geneticist and expert in newborn errors of metabolism, Dr. Berry sees both child and adult patients for genetic consultation at the University of Minnesota Physicians Pediatric Specialty Clinic. Joining her is also Whitney Thompson. Whitney Thompson is currently in her third year at the University of Minnesota Medical School. She received her BA in nutrition from Cornell University and her master's in medical genetics from the University of Cambridge. She plans to pursue a career in pediatrics or pediatric surgery, and she's been very involved in the surveys and parent surveys regarding newborn screening. At this time, I'm going to mute all the lines except for the presenter so that we have clear communication and presentation.
The conference has been muted.
Very happy to have the opportunity to present to you this in a second of series about newborn screening, communication of newborn screening results. And in this particular presentation, we're going to focus on return of normal results, an area that is often neglected, it turns out. Next slide, please. In this presentation, we're going to define what normal newborn screening results are and emphasize that this does not mean that there are no problems. That we're going to help you recognize the limitations of the newborn screen itself. We're also going to talk about current practices for providing normal newborn screening results to families and help to identify where improvements are needed for efficient and effective communication of those normal newborn screening results to families. Next slide. So what is a normal newborn screening result? What this means is that the child who has been screened is at low risk for having the conditions that are being screened for. Newborn screening is a risk assessment. It's not a diagnostic test. So when you have a normal or negative screen, it means that the child is unlikely to have the conditions being screened. There are things that can interfere with the appropriate interpretation of these results. These include infant transfusion, and typically this is ameliorated by people doing a sample before transfusion takes place. If the sample is taken too early or too late, this can interfere with the appropriate interpretation of the screen. And finally, feeding status can make a difference in the interpretation of the screening result. There are some important things that you should think about when you're communicating results from the normal newborn screen. First, the result really indicates that the child is at low risk for having the condition on the newborn screening panel. Second, the family should be aware that no further action was needed at the time. So if you've had a final result that says negative or normal, you don't need to do anything else. Finally, the screening is not diagnostic, and so the family should be aware that newborn screening doesn't screen for all health conditions and that one should remain clinically vigilant. It turns out, of course, that more than 95% of U.S. newborn blood spots results are normal, which is the expected outcome. And so this is something that most of you should have already experienced in your practices. Next slide, please. So just a quick note on terminology. Depending on where you are, different states use different terminology to refer to these results. Sometimes they sign the result out as normal. Sometimes it's referred to as negative. It turns out that that can be confusing at times to families to call it negative because they don't always know what that implies. Saying it's within normal limits or in range is probably more accurate, but each state uses a different nomenclature. For this presentation, I'm going to primarily refer to the results that are low-risk outcome as normal. So what we may see in your own practice may be different, but we're talking about the same thing. Next slide, please. I want to mention false normal results that are also sometimes referred to as false negative. In my own state, in Minnesota, these are referred to as false negatives. And what happens in that case, it means that the screen did not pick up an abnormal state. What you should remember as you look at those normal results is that a negative result means that the screen was normal for that particular disorder and no follow-up is required. But because newborn screening isn't diagnostic, false negative results may occur. So newborn screening can never replace diagnostic testing. And that should be in the back of your mind as you look at those reassuring results. While false normal results are rare, they are hard to track, and of course they have serious health implications. Next slide. I'm going to show you a very graphic example of that. This is, in some ways, this presentation is Leo's story, and Leo's mom asked that we share her experience so that others could learn from what she experienced. Leo had a normal newborn blood spot screen. That is, that he was assessed as having low risk to have metabolic conditions. However, he was diagnosed with a very specific rare inborn error of metabolism called cobalamin A methylmalonic acidemia when he was 16 months of age after suffering a stroke that resulted in permanent brain damage. His mom told us that she didn't remember receiving Leo's results of the newborn screen until after his stroke. She remembers being told no news is good news by someone from the hospital. It would have been helpful to her in her recollection if she had been aware that the screen is a screen and not a diagnostic test. And with that in mind, we hope that you also will keep that in mind as you share normal newborn screen results. Next slide, please. What's on the newborn screen and who gets the result? You may recall from our first presentation that the newborn screening typically has three parts. There's a hearing screening, and this is an objective test to determine hearing loss. And results are available at the time that the screening is done and provided to the family at the time that the testing is done. In a similar fashion, for pulse oximetry screening, the screen detects the presence of low blood oxygen, which may indicate an undetected critical congenital heart disease. And again, the results are presented to the family at the time of the testing. Newborn blood spot screening is different in that the baby's heel is pricked to collect a sample of blood. The screening card is sent to a state Department of Health for analysis. It has contact information for a family and the primary provider or the person who signed the card when it was sent, but results reporting is more complicated. And we're going to go through this really briefly. Next slide. At the time that the blood spot is done, there's a process that takes place before testing. Ideally, one hopes that families have received some education about screening before the sample is collected, ideally in the prenatal period, but at minimum at the time that the collection takes place. Blood spot samples are typically collected between 24 and 48 hours of age. There are minor exceptions to that, again, primarily due with transfusion. But as a general rule, between 24 and 48 hours of age. Specimens need to be dried carefully, and it seems funny to call this out, but if you don't dry the sample carefully in a horizontal position for at least 3 hours before submission, the sample will not be satisfactory. Samples are sent to the state screening program, and they should be sent as promptly as possible following drying. Ideally, within 24 hours of collection, states are undergoing quality improvement processes to try and reduce the time after collection with delivery, most employing couriers to accomplish that. Next slide. The results from testing should be available around 7 days after birth. Positive results, or those that indicate a high risk for a condition, may well and are often available sooner than that. Normal results, however, are provided back to the submitting birth facility and should be alerted to the primary care provider. This is a point of challenge to make sure that results are received, and you may end up needing to find a way in your own practice to assure that you have received the results of the screening test, either to prove that it's been done and or that it was normal. Positive results are typically called out to the primary provider and or to the specialist, depending on your location. Different places do it different ways. But positive results are usually something that brings a personal alert from the Department of Health. The family should, of course, be notified by the primary provider or specialist as soon as possible about a positive result. But the normal results also need to be provided to the family after testing. Next slide. What we'd like to recommend about what you should provide to families about their normal newborn screening results are that the test was done, that you've received the normal result. We would like to have you generally describe to families what's on the screening panel. It's not like you have to sit down and read out the 54 different conditions. That's not the purpose. A general description of the nature of newborn screening and what high-risk conditions are being assessed is typically plenty and as much as a family really needs to know. It is important that families know the limitations of a screening test because a normal result doesn't preclude the possibility of future disease, either of one of the conditions that's on the screen or other conditions. And so a brief description of what symptoms to be on the lookout for despite the normal results can help families be aware of the kinds of things that they should watch for. Next slide. It is ICD-10. What a miracle. It gave us codes for people who would run into a jet engine blade, but it also gave us this magnificent code, which is a diagnosis code that you can use both to essentially mark in your chart that you have accomplished this activity by using this diagnostic code, Z13.228, and it allows you to document that you've done a communication about a newborn screen. So it also helps with your billing practice. If you choose to use this as the primary element for billing in a given encounter, we recommend that you code by time based on expert opinion from our coding and billing staff. However, if you do this as part of a normal newborn visit at 2 weeks of age, simply adding this diagnosis code helps you know in future evaluation of the chart that this conversation has taken place. We also recommend, if you use a medical record that allows you to do so, that you have a programmed discussion of what information you provided to the family. I created a dot phrase in EPIC for those of you who happen to use that that's specifically related to Minnesota but could easily be adapted to anyone else. Adding this diagnostic code will help improve your reimbursement, and it also documents giving the result for future reference in the chart. Adding the dot phrase further enhances that. Next slide. We wanted to know a little bit more about what practices were doing with regard to giving out newborn screening results. So a quality assurance project was undertaken to assess this further. I'm going to turn the podium over to Whitney Thompson, who undertook this project.
So as we just discussed, obtaining the newborn blood spots and getting them back to the person who's going to ultimately give them to the families is a very complicated process. And so therefore, it's very understandable that normal results aren't always returned to the families. And if they are, that families may not even remember getting these results because so many things are happening at that first well-child visit. This led us to initiate a quality improvement project between the Minnesota Department of Health and the University of Minnesota to assess if families received and understood their normal screening results, how normal newborn blood spot results are handled at several diverse clinics, and to assess where improvements are needed for the efficient and effective communication of normal results to providers and families. The ultimate aim of this project was to make normal result reporting a more memorable experience for parents. Next slide, please. One of the first questions we sought to answer was, do parents across the state currently receive their normal results? We assessed this with a survey sent to parents 4 weeks after birth, with the idea in mind that these results should be available by this point and reported to parents at that 2-week well-child visit. With this survey, we chose to target families of babies with a normal blood spot result who received care at specific clinics across the state. These clinics were of varying sizes and patient populations, with number of newborn visits each month ranging from 15 to 180. By targeting specific clinics, we were simultaneously able to learn from the parents' perspective how these clinics were doing with their normal results, and at the same time to investigate how those specific clinics handled results from the provider's perspectives. I'll come back to this a little bit later. The survey itself assessed parents' familiarity with the newborn blood spot tests, whether they received their child's results, and, if so, how they received them. There was also room for them to provide comments on their experience receiving or not receiving newborn blood spot results. As you can see, according to the 400 surveys that we received back, over 50% of parents asserted that they either did not receive their child's normal newborn blood spot results or they don't know if they received them. Only 47% reported receiving these results, and some of these were only after the parents asked for them. Next slide, please. When this question is stratified by the specific clinics, we can see here on the left that some clinics are doing better than others, but no clinic is reporting results back close to 100% of the time. Approximately, on average, 1/3 to 2/3 of parents whose babies were seen at each of these clinics reported receiving their newborn blood spot results back. Another survey question asked those parents who did receive results how they were reported to them. The most common response at 45% was a verbal report of the results at a clinic visit by the provider. About a quarter of parents reported that they received results with a letter or brochure, with online patient portal the next most popular method after that. Some of these parents did note on the comment section at the bottom that they had to request the results themselves. The bottom line here is that there are variable practices for delivering normal newborn blood spot results between clinics within the same state and even between providers at the same clinical practice. Next slide, please. Another part of this project, as I mentioned earlier, was to assess how results are handled from the providers' perspectives at these same clinics where the parents were surveyed. When we spoke with the providers at each of these clinics, we found wide variation from one clinic to the next, and as I mentioned before, even variation from one provider to the next within the same clinic. The general theme for the clinics that felt they had a good handle on their normal results was that having something or someone in place to ensure that results were in the chart before that 2-week well-child visit made it much more likely that they were discussed early. Some clinics had a specific point person responsible for this, and this ultimately ensured that the results were available before the visit and were more likely to be discussed. For the clinics that felt less confident about their handle on normal newborn blood spot results, there were some things they reported as barriers that prevented them from doing better. One clinic in particular required patients to sign a release form before the results could be obtained, which was a misconception that the clinic had and is not at all necessary. And once this was cleared up, they were getting results back much faster. Many clinics noted difficulty communicating results without standardized or accurate materials available in multiple languages. These factors ultimately made it harder to get the results into the patient charts by that 2-week well-child visit, and ultimately much more difficult to communicate what the results meant to a diverse population. Next slide, please. On the survey as well, we asked parents how they would prefer to receive their child's normal results. By far, the most desirable method that parents identified was a conversation with their provider at a clinic visit. Following in popularity were electronic methods, including email and online patient portal messaging. Important to note here is that an even higher proportion of parents actually indicated wanting results at a clinic visit than appears here in this graph, as most chose that as their first choice, and then a second or third method as well to complement that conversation with the provider. This was also reflected in the comment section of the surveys as well. Next slide, please. So what role should the primary care provider play in providing these results? Ultimately, the primary care provider and supporting staff should ensure that the screening results are obtained and in the EMR for all patients prior to that first well-child visit, likely at 2 weeks. The results should then be provided to families during the first well-child visit, regardless of the results. Often, this is the only opportunity for parents to receive their child's results and clear up misconceptions about what might be on the screening test. Next slide, please. So as I mentioned earlier, the last question on the survey asked parents, were you satisfied with your experience getting your child's newborn screening results? How could it be improved? We received a nearly equal number of written comments from parents who received their results versus those who did not. Here are a few examples of some of the most common types of comments that we received on the surveys. No, I didn't receive any results. Assume that no news is good news. Smiley face. Pediatrician briefly mentioned my son's results came back good. It could be shared at appointment in better detail with a copy of the results, PDF or paper. I'm not even sure what blood type my son is. My understanding is you only receive results if they are abnormal. This seems sufficient to me. I don't know if I ever received my child's newborn screening results. Since I don't remember getting anything, I assume all is fine. However, the fact that I'm not sure I got results is a problem. So as I mentioned, these are some of the most common themes that we saw throughout the comments. Many of these were repeated over and over again, with the most common among the comments being, no news is good news. Next slide, please. In response to the comments from families on the surveys, we created a normal blood spot results fact sheet in order to aid the conversation about normal results and make it a more memorable experience for families. The fact sheet answers common questions and misconceptions about screening. It also incorporates the state's current screening panel on the back, which is not pictured here. It also provides a resource for families to reference throughout the conversation as well as afterwards at home. Prompts parents to remain vigilant about their child's health and continue looking for important signs and health concerns despite a normal result. And ultimately, the goal of this is to reach a broad audience through translation into multiple languages, which is something several clinics that we surveyed had mentioned having a difficult time with. Next slide. So we tested this fact sheet in 2 clinics that we had previously surveyed families from, so those that were initially as part of this project. Providers at these clinics were briefly educated about the fact sheet and were given a choice of how best to incorporate it into their practice. The post-intervention data collection is ongoing currently, but when comparing the survey results prior to the intervention versus afterwards at these 2 clinics, the percentage of parents indicating that they received their normal newborn blood spot results jumped from 45% to 73%, demonstrating that just a little bit of provider education as well as the right materials can go a long way. These results demonstrate that effectively providing these results in a memorable way to families is very attainable. Next slide. So as we have discussed today, no news is not good news. It's just no news. Families really do want their normal newborn blood screen results back, along with an in-person explanation of what the results mean whenever this is possible. Your participation in this MOC truly will make a difference. Thank you for listening.
And now we're happy to answer any questions about this or other elements of the MOC4 activity.
Okay.
Kathy,
I'll
assume
unmute.
you will be able to open the lines then?
Yep, I'll open the lines to everyone, and I just want to caution before I do that, if you do have background noise, if you could close the door or try to move into a little bit quieter area, since we're going to have probably 30 to 40 people with their background noise on at the same time. So we'll take questions on the presentation first, and then after that we'll answer questions about the baseline audit that all of you completed and the AAP KETA system with the link coming to you later today.
The conference has been unmuted. The conference has been unmuted.
Any questions for Sue or Whitney?
Just a note of the fact sheet that we referred to. We're going to post that on the project website, and Kathy will provide information and a link to that if you want to incorporate it. It's a document that can be altered. It's not fancy. So right now it's set up for Minnesota. It could easily have your own state's information dropped into the document if you wanted to use it in your own clinics.
Sounds good. And that was one of the questions that just came in, is could they get a copy of the handout? And I think the important thing is that it can be customized to your state and to your clinic or your health system. So that will be available and sent out after the presentation.
Yeah, right now it's unbranded, except it does have the Minnesota links in it because that's how we prepared it. And the other thing I would say is we also have a Spanish language version of this. That's the one alternative language that we have been able to accomplish thus far.
I'm listening to it on my phone. No, she's good.
Other questions? This is Kathy, and one of the things that I noticed from the baseline audits, and we have a number of those that have been returned already, and those baseline audits took place either in August or September, but there was a large number of clinics that either didn't have the documentation that these results were discussed with the parents, or they didn't know if they were discussed with the parents. So I think the comments in this presentation clearly are on point in how important it is, and that the parents are really looking for this information too. Any questions? If you're on mute, you can unmute yourself and ask questions of Dr. Berry or Whitney Thompson.
Kathy, we should mention that the third in these series will be talking about how to give back abnormal or borderline results. We hope that's a rare event, but it's helpful to have some information about how you approach that. So we're looking forward to sharing that in the next one of these series of 3 presentations about communication of newborn screening results.
And I did see from the baseline audits that we did have some of those rare events happen that were reported from clinics. And so as a follow-up to this session, as Sue mentioned, we'll be talking a little bit more detail about those abnormal results and how they're handled. Other questions? You can either type them in on the screen or just ask them out loud. And if you have questions that come up afterwards, after the session, or you think of something after the session, if you want to send an email to karens@mnaap.org, I can certainly forward those questions on to Dr. Berry and to Whitney Thompson for their responses. And with that, maybe we'll open the floor for questions on your baseline audits and what you found from your clinics, and you don't have to give specifics, but what you'd identified as your quality improvement initiative for your second month of this particular MOC4. Comments from those on the phone or at their computer? We had just kind of in summary, what we had reported were everything from setting up a new system in the clinic to handle the results for newborn screenings, having some type of electronic medical record tip or smart word that would be used in order to document that the newborn screening results were given. Some clinics had a fact sheet type of thing that they were planning on giving to the parents. So we've seen a number of different initiatives that are being undertaken after reviewing the baseline data. Anything specific from those on the call? We have a very quiet group. They're probably having lunch while we're talking. So. And the Canvas system that you'll be receiving the link to here today has been tested now multiple times in order to get it to a point that's going to be usable. I've tried to enter in your baseline data into your clinic profile. It's set up, and then you will be able to enter in your second and third audit data in addition to what your quality improvement initiatives are during that time frame. It then plots the data over time from your baseline to your third audit, so you can see what those changes or improvements are in the various measures that are identified. With this particular link, you will sign into the AAP website. Those that are AAP members have a login information. They're asked for their login information, and then it will take you to this screen. You will then find your clinic on the screen, and then you'll be able to see not only the resources, the past archived copies of these webinars, various forms. This is where we can also put the fact sheet template that would be available for you to customize for your clinic. And then also the place where you will then enter your data for your audit number 2 and audit number 3. For those that are not AAP members, you'll be given a link to set up a temporary AAP password so that you have access to this. And this password is set up just so that you have access to the KETA system and giving you full access to all the information that would be recorded at that site. Here is another question that came in. It says, I thought I was going to get a letter notification, but this presentation makes me want to go back to integrating it into my 2-week clinic note. But the EMR system note doesn't include a prompt for that, so it's easy to forget. And I think this is one of the issues that some other clinics have mentioned too, is that their EMR system isn't as flexible as what they had hoped for to be able to include a prompt such as the newborn screening communication in the system directly. Any other comments, questions?
This is Sue. Occasionally, depending on what system you have and how responsive your vendor is, you can have that programming incorporated, but that's a challenge for, I think, all of us who use an EMR to have it help us remember what we need to do. But I think having a prompt, if it can be programmed, it'd be really valuable. So good luck, and I hope that can happen for that particular, for anybody who wants to do it.
Any other questions? And again, we'll get out the date for the next webinar on the abnormal results to you as soon as we have a date tied down. We'll be archiving this webinar, and that link will be available for those that were unable to listen at this time. They can listen at a subsequent date. Any other final comments, Sue or Whitney or Matt?
Only
None
that
for me, thank you. That was great.
Only that we're happy to hear any additional questions that come up as time moves forward. So please just touch base with Kathy, and she'll make sure we get those answers back to you.
And do we have any parents that are on the line that had some comments or any concerns related to newborn screening results that they had received? We include parents on this particular project because their input's been so valuable in addressing some of the topics to present.
Yeah, I would mention that part of the way we were able to prepare the fact sheet was with input from parents about what they would have appreciated knowing more about.
All right. Well, thank you very much. We'll give you back the rest of your lunch hour and look forward to seeing the results for your second audit from your clinic on communicating newborn screening results, and we'll provide you with information to the link to the KETA system for plotting those results, and then also for the third webinar. Thank you so much, and have a great week.
Thanks, Kathy.
Thank you.
Thanks, everyone.
Thanks, everybody.